colleagues. Welcome to the 5th annual OncoAlert Colloquium, a comprehensive review of the year's top scientific advancements organized by Tumor Group. The Colloquium is made possible thanks to our partners at the European Society of Gynecological Oncology, the European Society of Surgical Oncology, the Multidisciplinary Association of Supportive Care in Cancer, and the International Society of Geriatric Oncology. We're also grateful for the tremendous collaboration from the Advanced Prostate Cancer Consensus Conference, ABC Global Alliance in Breast Cancer, the Belgian Society of Medical Oncology, KidneyCan, the GARD Consortium, and our friends at GUcast. We would like to thank Pfizer and Roche for partly sponsoring this year's colloquium, and we would like to remind you that all presentations that you will see have been made independently by presenters with no industry influence on topics or content. The colloquium is divided into 7 days. Day 1, GU Oncology. Day 2, Lung Cancer and Supportive Care. Day 3, Breast Cancer. Day 4, GI Oncology. Day 5, Gynecological Cancers. Day 6, Hematology, Sarcoma, Lymphoma, and Geriatric Oncology. And Day 7, How I Treat Cancer When Facing Limited Resources. Today we start off with Gynecological Oncology, and a pleasure to introduce today's speakers who are all part of the European Society of Gynecological Oncology. Dr. Nicolo Bizzarri, Dr. Domenica Lorusso, Dr. Aleksandra Strojna, Dr. Annamaria Ferrero, Dr. Alejandra Martinez, Dr. Isabelle Ray-Coquard, Dr. Christina Fotopoulou, Dr. Maike Unk, Dr. Cyrus Chargari. And we finish off with a patient advocate perspective with Ms. Kim Hilcher, co-chair of Engage. We hope that you enjoy this 5th day of the colloquium, and now, without further ado, Dr. Bizzarri.
Hello to everyone. My name is Nicolo Bizzarri and I am a gynecologic oncologist at Policlinico Agostino Gemelli in Rome, Italy. And it's a great pleasure and honor today for me to be here to speak on behalf of European Society of Gynecologic Oncology at the OncoAlert Colloquium. And I will be talking about surgical trials in cervical cancer, which has been considered practice changing in 2024. This is the outline of my talk. And I will be talking about SHAPE trial, CENTIX trial, GOG 278 trial, and the final results of the LUCK trial, and finally, summary and conclusion. Starting with the SHAPE trial. The SHAPE trial was a trial with the principal investigator being Mary Plant from Canada, and it was a prospective international multicenter randomized trial Phase 3, which included patients with low-risk cervix cancer, defined as in the left upper corner of this slide, and it randomized patients to receive either simple hysterectomy or radical hysterectomy, with the primary endpoint being pelvic recurrence rate at 3 years. In terms of results, 700 patients, 350 per group, were randomized, and the graph shows that the main result of the study was that there was no difference in pelvic recurrence rate at 3 years. On the other hand, fewer urological surgical complications were seen in the simple hysterectomy group, and a better quality of life and sexual health were seen in the simple hysterectomy group. Therefore, the conclusion of the study was that for patients with low-risk cervix cancer, defined as below 2 centimeters with limited stromal infiltration, the simple hysterectomy is sufficient and can be the new standard of care. I would like also to discuss about the CENTIX trial. While the SHAPE trial, which we have just discussed, was published in 2024 in New England Journal of Medicine, the CENTIX trial has not been published yet, but it was presented by the PI, David Cibula, at the ESGO Congress 2024. The trial design was an international prospective observational trial on sentinel lymph node biopsy in patients with early-stage cervix cancer below 4 centimeters. patient underwent sentinel lymph node biopsy with frozen section, and if the frozen section of the sentinel node showed no evidence of metastasis, they underwent radical hysterectomy and then sentinel node ultrastaging at the final histology. The sentinel node pathology was centralized in the at the PI site, which was Prague in Czech Republic. In terms of results, bilateral detection rate was found in 92.3% of the cases, with a median of 3 sentinel nodes per patient. And interestingly, isolated sentinel node metastasis in the second level, meaning common iliac and presacral, skipping the first level being obturator and external iliac, was only 1.3%. Here is the main result of the study. The primary endpoint was disease-free survival, and the study showed that with a median follow-up of 47 months, the disease-free survival of the CENTIX trial was comparable to the one showed by previously published trial and the up-to-date literature available. For this reason, the conclusion was that sentinel lymph node alone can be considered a safe alternative to lymphadenectomy from the oncological point of view. Another result of the study was that from a cost effectiveness point of view, in terms of ultrastaging analysis, the number of 4 levels was identified as the best one to detect sentinel lymph node metastasis, as 4 levels identified more than 90% of cases with micro and macro metastasis. The GOG 2078, with PI being Alan Covens from Canada, was presented this year at ESGO meeting, and in 2024, and it had the endpoint to assess the perioperative and oncological outcomes of patients with early stage low risk cervix cancer undergoing non-radical hysterectomy. They included 152 simple hysterectomy and 72 cone biopsy only patients with lymphadenectomy. All patients to be included had to have undergone a previous colonization with negative surgical margins and the depth of invasion less than 10 millimeters. In terms of adverse events, these adverse events of grade 3 or higher occurred in 5% of hysterectomy patients and none in the cone biopsy patients. In terms of oncological outcomes, while there was no recurrence or death in patients undergoing hysterectomy group, there was a 4.4% recurrence rate in patients undergoing colonization only. So the conclusion was that non-radical surgery for early-stage cervix cancer appeared safe with low perioperative morbidity, but recurrences in cervix after fertility sparing could occur even in low-risk population. Lastly, I would like to discuss the publication of the final update of the LUC trial. This was published in Journal of Clinical Oncology 2024 by Pedro Ramirez and co-authors. The results of the LUC trial are well known to all of us, and they showed that minimal invasive radical hysterectomy had lower recurrence-free and overall survival when compared to open radical hysterectomy in this randomized study. The final results, with all patients reaching the completion of the follow-up, confirmed that higher recurrence rate and worse overall survival were seen in the minimally invasive surgery group. When sub-analysis, exploratory analysis were conducted, the authors highlighted very well that these were not powered analysis. They showed that when the patient was stratified for cone biopsy, there was no difference in patient undergoing cone biopsy when the two approaches were compared. On the other hand, when tumors with diameter less than 2 centimeters were analyzed, there was a higher risk of recurrence after statistical correction, also in this subgroup of patients in the minimally invasive arm. In other words, even in low-risk tumor below 2 centimeters, patients undergoing minimally invasive approach had worse survival outcomes. So in conclusion, to discuss about practice-changing trials in 2024, we can say that simple hysterectomy is the new standard of care for low-risk cervical cancer below 2 centimeters with limited stromal infiltration, according to the SHAPE trial. Sentinel node biopsy alone was a safe alternative to systematic lymphadenectomy from the SENTIX trial. Non-radical surgery for early-stage cervical cancer appeared safe with low perioperative morbidity, and this was demonstrated by the GOG 2078 trial. And lastly, the final results from the LAC trial confirmed worse survival outcomes in patients undergoing minimal invasive radical hysterectomy, even in patients with tumor below 2 centimeters. With this, I would like to thank you all for the attention, and a special thank to Gil Morgan and the OncoAlert team for this amazing OncoAlert colloquium, and thank you for letting me be part of this project. Thank you again, and see you soon.
So thank you so much for inviting me to discuss the best of the year in the medical treatment of cervical cancer. It was very an interesting year. As you know, cervical cancer still represents a huge unmet clinical need, with more than 600,000 new cases every year. And regardless, unfortunately, the presence and the possibility to have primary and secondary preventive strategies, the incidence of this tumor is increasing over time. Stage of disease is the most important prognostic factor. Nicolo will speak about the rule of surgery for stage 1 tumor. For locally advanced disease, concurrent chemoradiation has been since more than 25 years the standard of care, and for advanced disease we have chemo plus immunotherapy. But here we are. When the tumor recurs, the median overall survival is 28 months. And even though there was an increase for sure since 2024, still the expectation of life for our patient when the tumor recurs is less than 3 years. And we decided to move immunotherapy in a setting in which the tumor can potentially be cured. So the incidence of the tumor in the setting of locally advanced reflects the primary and secondary prevention. And in Europe, we have about 26% of new cases of locally advanced disease per year. In the last 25 years, we had used concurrent chemoradiation after the publication of 5 randomized trials that reported that when we combine cisplatin to radiotherapy, we increase by 6% the overall survival. But the benefit is larger in stage 1, 2, but for patients with high risk locally advanced, there is still a large room of improvement, and we try to improve. We try to improve combining chemo to concurrent chemoradiation, but the majority of the studies in this large 200 and 500 meta-analysis did not report a significant benefit in this population with an added toxicity. In the reality, in the last years, the great step forward was performed by radiotherapy itself, because we moved from 2D brachytherapy to 3D brachytherapy to the modern image-guided brachytherapy that has reported to increase local control. And in cervical cancer, local control means overall survival, but also to reduce the toxicity. And this is what we can expect actually by modern radiotherapy: a local control more than 92%, 5-year overall survival of about 75%, which is about 80% in stage 2B. In the last year, we saw 2 trials that try to further improve the control of disease in the setting of locally advanced. This is the interlace. The Interlace was a randomized phase 3 trial that enrolled 500 patients. At the beginning, these patients should be 700, and then the trial design was amended and the number of patients reduced to 500. These patients with locally advanced disease were randomized to induction chemotherapy with weekly carboplatin paclitaxel for 6 weeks, and then 1 week later concurrent chemoradiation or concurrent chemoradiation. The trial was a long 10-year trial, and the quality of radiotherapy, the technique of radiotherapy was different with what we use now. In fact, the dose was lower than the standard 78 gray. The trial enrolled a low-risk locally advanced population. 76% were stage 2, 10% stage 1, and only 14% stage 3 and 4. Most of patients were squamous tumor, and the majority had node negative. 60% of patients had node negative. The trial reported a significant increase in 5-year progression-free survival from 64 to 73%, and 5-year overall survival from 72 to 8%. The major benefit of the trial was reported in terms not of local control but distant metastasis, and I was quite surprised that the PFS in the trial was evaluated not with a well-defined radiological schedule, but with the gynecological visit with radiological exams performed at physician discretion. And this makes it very difficult to me to understand how distant metastasis can be evaluated by gynecological visit. And also when I look at the local control here is 84%. We are quite distant from the more than 92% that is provided by modern radiotherapy. Unfortunately, the combination of induction chemotherapy plus concurrent chemoradiation jeopardized the possibility to complete concurrent chemoradiation in up to 30% of patients because of adverse events. And when I look at the forest plot, it seems that in the 30% of patients in this trial that receive modern image-guided radiotherapy, the benefit of induction chemotherapy is not so clear, thus suggesting that probably in the context of modern radiotherapy, the added benefit of induction chemo is not defined. So for all this reason and for all this limitation, this trial has been not received everywhere. But there were some data suggesting that the addition of immunotherapy to radiotherapy may increase the benefit of radiotherapy, and that's the endpoint of ENGOT 611, the other randomized trial that we saw in the last year. Here, patients with locally advanced high-risk cervical cancer, FIGO 2014, stage 1B2 to B and node-positive disease, or FIGO stage 3 and 4A, regardless lymphnodal status, were randomized to receive concurrent chemoradiation plus pembrolizumab 200 milligram every 3 weeks for 5 cycles, followed by pembrolizumab 400 milligram every 6 weeks for 15 cycles, or concurrent chemoradiation plus placebo. The trial has 2 primary endpoints, progression-free and overall survival, and a good quality control because there was an external vendor that provided rigorous site validation and review all the treatment, radiotherapy treatment plan before patients start the treatment. The trial enrolled 1,060 patients, and these were high-risk patients, 56% at stage 3 and 4A, 85% node positive, and up to 90% of patients receive modern image-guided standard radiotherapy at an appropriate dose. And 75% of patients completed treatment between 56 days, and the median dose was 87 gray. So in the context of modern radiotherapy, the addition of pembrolizumab significantly increased the progression-free survival. At 2 years, 30% reduction in the risk of progression. At 3 years, 32% reduction in the risk of progression, with all the patients gained the same benefit. Also, the stage 1B2 to B and node positive that with a longer follow-up and a higher number of events get benefit from pembro. But more important, there was a significant 33% reduction in the risk of death with an overall survival at 3 years that increased from 75 to 83%, and again, all patients get benefit. All the secondary endpoints were in favor, a higher overall response rate, longer duration of response, and the toxicity profile was very good. Only few more patients, 5% more patients, discontinued any treatment because of adverse event, and only one patient in pembro arm discontinued whole treatment because of a pembro not related adverse event. The incidence, type, and severity of adverse event were very similar. For sure, immune-related adverse events were dominant in pembro-treated patients, but there was not overlapping toxicity in terms of diarrhea and colitis, and the quality of life was very good. So based on this data, FDA and also EMA has approved the pembro in combination with chemoradiation in FIGO stage 3C and 4A. So what did change in the last year? We have a new standard of care in locally advanced FIGO stage 3 and 4A. Pembro in combination with chemoradiation increased progression-free and overall survival. For the reason we discussed, the role of induction chemotherapy in the setting of modern radiotherapy is not being defined. Thank you so much for your attention.
Welcome. I'm Annamaria Ferrero, a gynecologist from the University of Torino, Mauriziano Hospital. I will present the best of the year in the medical treatment of endometrial cancer. Endometrial cancer is now the queen in gynecological oncology, especially concerning the medical treatment. And several medical trials have been presented during 2024 in the major meetings on gynecological oncology. The main topic has been immunotherapy in endometrial cancer, and I will focus on some of these trials. At ESGO 2024, Brian Slolowicz presented the transformative clinical trials in the advanced stage and the recurrent setting, and especially the GY18 trial, DuoE, Ruby, and the ATTENT trial, confirming the benefit of IO plus chemo in terms of progression-free survival, both in the dMMR and in the pMMR population. We have to note that pMMR population represent at least 75% of endometrial cancer patients. Concerning the Ruby trial, data on overall survival has been presented at ASCO at ESGO 2024 for part 1, confirming the statistically significant benefit of dostarlimab plus chemo in the overall population. And in the Ruby trial, part 1, molecular classification was performed for all participants with full exome sequencing, and at ESGO 2024, the exploratory analysis according to molecular subgroup has been presented, confirming the advantages both in the progression-free survival and overall survival in all the subgroups. Data of the Ruby Part 2 trial has also been presented at SGO. In the Part 2 trial, dostarlimab has been combined with niraparib, and also in this trial, the benefit has been showed, especially in the pMMR population. And the data is being confirmed also in the exploratory analysis presented at ESMO Gyn. And so we have the hypothesis that PARP inhibitors could be used especially in the subgroup of pMMR population. Also, the ATTENT trial has been presented during 2024. In the ATTENT trial, the combination with atezolizumab has been assessed, and at ESGO, data on according to ethnicity has been presented, confirming the benefit of the combination both in the Asian and the non-Asian population in the dMMR population, while in the pMMR population seemed that the combination of with atezolizumab was detrimental. But we have to note that the two populations were at least different concerning several patient characteristics and previous treatments. At ESMO Gyneco, also data on the patient-reported outcomes and the quality-adjusted survival were presented, confirming again the benefit and improvement with the addition of atezolizumab. During the 2024, also data of the SIENDO trial were presented. In this trial, the maintenance role of selinexor was assessed, and in the subgroup of patients with the TP53 wild type, the benefit of this maintenance treatment was showed especially in the pMMR population. And these data were also presented at IGCS, and the conclusion was that TP53 wild type status may represent a predictive biomarker for selinector efficacy. Thus, this conclusion raises some discussion in several also symposia and state-of-the-art session, also because the DuoE data were presented, and in this trial both the primary endpoint were reached, and the benefit of the combination of durvalumab plus olaparib was shown especially in the pMMR population in terms of progression-free survival. In this pMMR population, several biomarkers were assessed, and it has been shown that there is a co-prevalence of many biomarkers, but it was extremely important to show that the benefit in terms of progression-free survival was present according to all the biomarker subgroup, both in the durvalumab and the durvalumab plus olaparib combination. So in this subpopulation, the pMMR population, the benefit could be reached in all the range of biomarker and histological subgroup. The last few trials I will present are two trials trying to show the benefit of immunotherapy in the first line or adjuvant setting. According to the result of the 775 trial, in the LEAP-001 trial, the combination of pembro and lenvatinib was evaluated in patient as at the first line, but the trial failed to show any benefit, both in terms of progression-free survival and the overall survival. So the combination of pembro and lenvatinib is an important combination, but only after progression following prior systemic therapy in any setting, both neoadjuvant and adjuvant setting. Also, the N11 trial assessing the combination of pembrolizumab plus chemo in the adjuvant setting failed to show any benefit in terms of disease-free survival. So, which are the practice-changing results from these trials in 2024? Surely we had the confirmation that dostarlimab plus chemo is the new standard of care for patients with primary, advanced, or recurrent endometrial cancer, regardless of MMR status. The addition of olaparib maintenance to durvalumab enhances the progression-free survival benefit, especially in the pMMR subpopulation with advanced or recurrent endometrial cancer across a range of biomarkers and histological subgroups. TP53 wild-type status may represent a predictive biomarker for selinexor efficacy in endometrial cancer, but the phase 3 trial is still ongoing. And then pembro lenvatinib should be regarded as a treatment option for pMMR endometrial cancer, but only with disease progression following prior systemic therapy in any set. For the future, we aim to have a personalized treatment according to biomarkers. Thank you for your attention.
Hello and welcome everyone. Dear colleagues, dear OncoAlert enthusiasts, it's my great pleasure to welcome you on the OncoAlert Colloquium 2024 on the updates on surgical trials in endometrial cancer. My name is Aleksandra Strojna and I'm Gynecology Fellow, currently working at Kliniken Essen-Mitte in Essen, Germany. And it's really my great pleasure to welcome you and to be here with the outstanding colleagues, friends. And I would like to thank Gil Morgan for this amazing initiative and invitation. So our task for this presentation is updates on surgical trials in endometrial cancer. So we need to discuss this topic today and what we have happened so far in this endometrial cancer field. We can see the increasing endometrial cancer clinical trials in the recent years, but in majority addressing the adjuvant and the systematic treatment. But we can definitely say that we have increasing interest in this topic. One of the major changes in recent years is, of course, new FIGO staging in molecular classification. So we have much more details. We have a difficult classification with subgroups, which can also address the target treatment, adjuvant treatment with the different subgroups. But we can also open and discuss the question of the role in surgery in this field. So do we have a shift treatment regarding the surgical treatment algorithm in the new era of molecular classification? We'll also try to discuss with the studies that we will discuss today the topic. So today I would like to highlight these 4 studies. Not all of them are the clinical trials. There are also 2 retrospective analyses, but I think they were to highlight. So we will discuss from trial regarding the nodal involvement in molecular classification, update of the already known Seneca study, DEAR model, which highlight the healthy lifestyle and nutritional in patients with endometrial cancer, and also the role of secondary surgery in recurrent endometrial cancer. So the first study highlight the impact of the molecular classification in predicting nodal involvement in early stage endometrial cancer. This study of the Italian group led by Giorgio Bogani showed us this is actually the only prospective study and showed us really different findings that we know so far from retrospective analysis. For example, from the Seneca study, which we'll shortly discuss after this one. So in this study, we have endometrial cancer early stage patients. It was at the end, the study population was 210. They were early disease patients with which were undergoing laparoscopic surgery, hysterectomy with bilateral slumping, oophorectomy, and SLN. The excluded patient with bulky nodes and peritoneal diseases, so actually with advanced disease which were detected during surgery, and also some patients were excluded because of inadequate results of molecular testing. And actually what was surprising and what the authors saw, that the patient with P53 abnormal group had the lowest nodal involvement rate, and it was 16.6%, while the polymutate patient showed high rates of nodal involvement. It was 20%, and both were significant. So actually we see it also in this table here that the rates point, these rates point to the absence of association between molecular classification and nodal metastasis in multivariate analysis. Of course, we can discuss here that some of the patients were excluding during the operation with the bulky nodes and peritoneal diseases. Most of them were P53 abnormal. This reduced the upstaging rates. But on the other hand, with this analysis, we see that in terms of the nodal positivity, only lymphovascular space invasion and myometrial invasion were actually significant. So the study showed that molecular features were not useful in predicting nodal disease, while deep myometrial invasion and LVOSE predicted the presence of the nodal disease in patients with apparently early stage endometrial cancer. And with this, we are going to the second study, which were also already discussed last year. With this study, we shortly discuss what we already know, but this is the update of the study, which try to answer the question, does it help to be operated in the high volume center? So the update of the study was presented during the ESGO Congress 2024 in Barcelona by Felix Boria on behalf of Seneca study. So shortly to remind all of you, the Seneca study is a retrospective review data from a patient with early stage endometrial cancer, stage 1 and 2. And in this study, we already know that the molecular types P53 and abnormal and mismatch repair deficient were associated with predicting lymph node involvement. So Actually, the study is a multicentric retrospective analysis. All the patients undergo the laparoscopy, hysterectomy with bilateral oophorectomy and SLN. And all the patients were tested for molecular classification. Patient exclusion criteria were presence of extrauterine disease and a previous lymphadenectomy. The updates try to answer the question which are already said. Does it help to be operating in a high volume center? So the authors try to address the question through the outcomes, surgical outcomes, compliance of quality indicators, and complications rate. So we know that ESGO have the center of accreditation, and regarding the endometrial cancer, we have the quality indicators. Two of them address the rate of the volume of the centers and the patient treated per year, and one of them is the number of the new cases, which is over 90. So what authors actually see? They differ the two groups, high volume centers and low volume centers. The total number of the patient was over 2,100. The both groups, they were not actually different of the basic characteristic, and they see actually the complication rate was significant higher in the low volume centers, both intraoperatively and postoperatively. The duration of the operation was 30 minutes shortened in the high volume centers. Blood loss was also lower. The rate of SLN detection was higher in the high volume centers. Also, the molecular profiling was percent of this was higher in the high volume centers. ESGO compliance rate was also higher in high quality centers. So actually, in this analysis of the Seneca study, the authors confirmed that the patient with early stage endometrial cancer who underwent surgery at a high volume center experienced improved surgical outcomes. So this gives us a question about the centralization of the care. The third study that I would like to highlight today is a DEAR model in overweight endometrial cancer patient, early disease, undergoing fertility-sparing treatment. It was a randomized controlled study for Chinese group, and the authors include in this study 72 patients. They were divided in the interventional group and follow-up group. Both were equal numbers of 36 patients. And this study highlights, it's not pure surgical study, but actually highlights how the healthy lifestyle and also nutritional status can impact the surgical and the patient outcome after the operation. As we said, it was single center randomized controlled trial, evaluated effectiveness of DEAR. DEAR goes for diet, exercise, activity, and recovery. Both groups were followed up for 6 months, and they have interventional for 6 months after the surgery. So the patient with early stage disease or atypical hyperplasia underwent the fertility sparing surgery. They get to this study. And the study results highlights that the DEAR group achieved significantly higher complete remission. It was 88.4% versus 57.1%, and it was significant. The time to complete remission did not differ significantly. And also we see straightly that in the interventional group, the patient had a lower median body weight. They have lower body mass index and lipid accumulation index to compare to the control group. So this study really highlights that patient outcome is much more better when we think about the healthy lifestyle and actually nutritional status. And the last study that I would like to highlight today is also the retrospective analysis from the Italian group under the lead of Virginia Vergue. The group analyzed retrospectively 331 patients with recurrent disease regarding the possibility to secondary cytoreductive surgery. The patients were from 3 centers. The data was collected between patient January 2010 and December 2021. The patients were actually categorized in the 3 groups. One group was without surgical interventional. The patients were only receiving the medical treatment. The second group was diagnostic laparoscopy without secondary cytoreductive surgery. And the last group was patient with laparoscopy followed by secondary cytoreductive surgery. And what actually we saw here so far in results, 56.2% of the patient, they undergo cytoreductive surgery, 17.2 only laparoscopy, and 26.7 receive only medical treatment. Patients undergoing secondary cytoreductive surgery were younger, with a lower body mass index and a better performance status and fewer comorbidities. Of course, as we can expect, single-site local regional relapse was common in secondary cytoreductive surgery patients, and there were some patterns and factors highlighted: age under 65 years, single-site relapse, lymph node and hematologic relapse were independent predictors of complete cytoreduction. So these factors were used to create a predictive model assigning a score between 0 and 1 to each of the factors. And what we can see, the authors reported that complete gross resection rates was 33% for a score 0, was 63 for a score of 1, and 86 for a score of 2. And for a score of 3 was already 93.3. This was a retrospective analysis. Not all of the patients also underwent the secondary cytoreductive surgery in this study, but definitely the study highlights the secondary surgery is possible in the recurrent disease, as well with the high complete resection rate. So we know that we need the prospective data, but this is the very important highlight of this year as well. And with this slide, I would like to highlight actually the still open question in the field of endometrial cancer and surgery. So we have unaddressed needs and open questions. And I think the studies that we discussed today only really answer this unanswered question. So the importance of surgical staging in the context of molecular classification, it's still the open question. The role of surgery in treating advanced and also recurrent disease. And the last thing that was also highlighted in the consensus of gynecologic cancer intergroup is the significance of exploring neoadjuvant therapy as a strategy of advanced stage disease. And with this slide, I would like to invite everyone for ESGO Congress 2025 in Rome. It will be amazing meeting with amazing data and a high quality content and amazing speakers. So it will be held between 20 and 23 of February 2025, of course, in Rome. And I would like to thank you all for watching the video and attending the OncoAlert Colloquium 2024. Thank you very much.
Hello everyone, my name is Isabelle Ray-Coquard. I'm medical oncologist working in the Centre Léon Bérard, Lyon, France. I'm professor of medical oncology and happy to speak with you today about what have changed in clinical practice for ovarian cancer in 2024. It's a very good way to start 2025. So as you remember in the first line setting, we have our ESMO, ESGO guidelines introduced the place of the surgery, the quality of the surgery, the treatment including chemotherapy plus or less BEV, and maintenance therapy with PARP, BEV, both, or only BEV. In this setting, we already report in 2022 and 2024 how a PARP inhibitor as olaparib can be able to increase overall survival for BRCA-mutated population in the SOLO-1 trial and for HRD positive population in the PAOLA-1 trial, including olaparib and BEV in this population. In 2024, the PRIMA results were available for overall survival, exploring the niraparib versus placebo in the maintenance therapy in the population of patients with residual disease post-upfront surgery or patients receiving neoadjuvant chemotherapy. But it is not exactly the same population than PAOLA-1. And in this population, PRIMA already report positive results with a long-term follow-up for PFS in the ITT population, but more importantly in the HRD positive population compared to the HRP, where finally, if we have a statistical positive results, the clinically meaningful results are not so high because we see only very few time benefit in this population. Considering the overall survival, unfortunately, PRIMA will not report difference in terms of overall survival between niraparib alone versus placebo in the ITT population, but also in the HRD positive population or HRP population. Where it was a little bit surprising is that also in the BRCA mutated population, we don't see a benefit in terms of overall survival compared to placebo. However, we have to note that the median overall survival remained very high in this population in the two groups of treatment. Interestingly, we anticipate that the subsequent use of PARP inhibitor can impair on that, and effectively close to 50% of the patient receive a PARP inhibitor in the control arm when they relapse, and close to 58% in the HRD BRCA mutated population, that it is finally quite similar to what we observe in PAOLA-1 trial. So how we can explain that in PRIMA we don't see a benefit in terms of overall survival? There is different hypotheses. First, we have to remember that PRIMA is not exactly the same trial in PAOLA-1 in terms of population. The combination with BEV in PAOLA-1 can make something compared to PARP inhibitor as a monotherapy. The role of upfront surgery with no residual disease, as we include in PAOLA-1 and in Athena, perhaps can play a role to explain the activity of PARP inhibitor, particularly when we are using them alone. What do you have to say about the dose intensity of PARP and safety between the different trials? And finally, we have to remember that 90% of the patients in PRIMA progress during the maintenance with PARP compared to only 35%. And we have seen recently in the publication that can impact. And finally, the role of the subsequent therapy as surgery and the use of BEV in PRIMA can also some hypotheses to explain the difference. What it is interesting also to note in 2024 is that we look at what's happened in terms of subsequent therapy in PAOLA-1, and we see that the patient received platinum-based chemotherapy seems to have a different impact if the patient progressed during PARP or after PARP. The multivariate analysis confirmed that the platinum-free interval, the quality of the surgery, the stage, and the progression during PARP impact on the next subsequent PFS in PAOLA-1. And effectively, when we look at what's happened for patients receiving platinum-based chemotherapy, we see that finally patients who progress during PARP did not have the same PFS than the patient who did not receive PARP or the patient who progressed after PARP. And what it is also interesting to note is that the patient who what it is interesting to note is that the patient who received again PARP after PARP in the PAOLA-1 trial or the patient who received PARP for the first time, we see some difference. And if you look at this clinical activity of PARP after PARP, we don't see a difference for the patient who did not receive PARP and the patient received PARP again if they did not progress during PARP. However, when the patient progressed during PARP, it seems that the quality of the PFS seems a little bit lower. However, it is retrospective analysis. We have to be careful and we need to confirm this data in a large randomized trial. Considering the role of immunotherapy, HATENA combination were reported this year, looking to the use of rucaparib plus nivolumab versus rucaparib alone. And unfortunately, what we see is that adding immunotherapy to PARP inhibitor did not bring any advantage to a patient as a maintenance therapy compared to rucaparib alone. And we can say that rucaparib alone do better, where the alpha ratio is 1.29 for the combination compared to the monotherapy. One of the reasons to explain is that the combination increases the side effect and possibly can explain these negative results. Another interesting and important results in 2024 is the arrival of EDC in ovarian cancer. There are several EDC on development right now, looking to different target, and you can see that the expression of the target can be different. However, the most advanced were the mirvetuximab soravtansine, where the phase 3 report positive results for this drug compared to standard of care in the platinum-resistant ovarian cancer population. We can see on this slide the PFS advantage, but also the overall survival advantage and the response rate advantage using this monotherapy, EDC targeting FR-alpha high population compared to chemotherapy. It is the first time since recently we see positive results in terms of overall survival, and we are waiting for the drug available for our patient in 2025. Finally, I would like to inform you about the low-grade serous ovarian cancer, where Susie Banerjee report the combination of avutometinib and defactinib, MEK inhibitor, and a FAK inhibitor, who report huge activity in this population resistant to chemotherapy. The response rate is 31%. The median time to response is only 3.7 months. The median duration of response is close to 3 years, and the patient can receive activity. Also, they receive MEK inhibitor before. We never seen such very good results before. It's really interesting for our patients. So if we want to speak about practice changing 2024 in the first line, maintenance therapy continue to be PARP plus or less BEV for BRCA mutated and HRD positive population. Olaparib report OS benefit alone or in combination with BEV in BRCA and HRD positive population. HRD negative subgroup remain a poor prognostic population where BEV is preferred option to PARP inhibitor right now, but we need to have more option in the future. There is no place today for PD-1 or PD-L1 inhibitor in combination with chemotherapy and or PARP inhibitor in advanced stage. We are waiting for a new trial coming soon. And in the relapse setting, we see the results of MIRASOL confirming the benefit of MIR soravtansine for high-grade ovarian cancer resistant to platinum-based chemotherapy. And the combination of MEK inhibitor plus FAK inhibitor reports strong activity, and we encourage patients to be included in the current large phase 3. Coming in 2025, we are waiting for first and killing trial where we will see if PD-1 inhibitor can bring something. This is the two last trial exploring the combination of immunotherapy plus PARP. There is new clinical trial with EDC targeting different receptor who will be interesting to explore in first line, particularly in the HRP population. In the relapse setting, we have ongoing large phase 3 exploring CDH6, Claudin 6, TROP2, HER2, who will be important to include our patient to find new clinical trial and new drug for this patient. Considering the rechallenge with PARP inhibitor for high-grade serous ovarian cancer who did not progress during the first line PARP plus or less BEV maintenance, and responding again to platinum-based chemotherapy remain an open question where we need to have large phase 3 to make the demonstration. And as I mentioned before, the ROM 301 randomized phase 3 trial with avutometinib and defactinib combination versus standard of care is an important large phase 3 for our patient in the relapse setting. Thank you so much for your attention and see you soon.
Dear friends, dear colleagues, good afternoon. So my name is Alejandra Martinez. I'm GYN oncologist in Toulouse, in the Comprehensive Cancer Center of Toulouse in France. And it's my pleasure to present you the updates on surgical trials for ovarian cancer. So what has changed in 2024? We're going to go through 3 questions. The first one addresses the role of lymphadenectomy after interval debulking surgery with the results of the Caracal trial that has been presented this year in ESMO and ASCO. And then we'll go over 2 questions for platinum-sensitive relapsed disease with the results of the SOC1 and the CHIBOR trial that have been published in 2024. So should we consider lymphadenectomy for advanced ovarian cancer? Well, we have the results of the LION trial after primary debulking surgery, and now we'll talk about the results of the Caracal trial. So just to remind you, the LION trial was a randomized phase 3 trial, which included patients with stage 2-4. Randomization was performed intraoperatively after primary debulking surgery once the resection was completed, and once there was no suspicion of metastatic lymph nodes on intraoperative examination. If not, the patient were excluded and were not randomized in the trial. So this trial did not show any survival advantage in favor of lymphadenectomy. So lymphadenectomy has been abandoned when there are no suspicious lymph nodes during primary debulking surgery. So the Caracal trial is also a randomized phase 3 trial, which included patients with stage 3-4 without suspicious lymph nodes on preoperative exam or during intraoperative examination that were randomized to pelvic and parotid lymphadenectomy or no lymphadenectomy, either after primary or interval debulking surgery. Stratification was performed according to surgical timing, and the primary endpoint of the trial was progression-free survival. This trial has been presented by Jean-Marc Lasse in ESMO ASCO 2024. So as you can see here, more than 85% of patients underwent complete cytoreduction, and the authors did not report any did not report a significant survival difference between lymphadenectomy and no lymphadenectomy. But there was more morbidity in the lymph node dissection arm and significantly more reoperations in patients who underwent lymphadenectomy. So the second question, should we consider surgery in patients with platinum-sensitive disease? So surgery should be discussed when relapse, when we have a platinum-sensitive relapse, which means that the platinum-free interval
is higher than 6 months since the end of chemotherapy, and this concerns the majority of patients with relapsed ovarian cancer, as you can see in the diagram on the right side. And we know that the longer the progression-free interval is and the more localized the disease is, the greater will be the survival benefit after surgery. So we have 3 randomized trials that have assessed this question. The most important one are the desktop studies. So the desktop one created a predictive score for complete cytoreduction, which is the ESGO score, which has 3 criteria: ECOG 0-1, no residual disease after primary surgery, and ascites less than 500 milliliters. When the ESGO score is positive, we can predict complete cytoreduction in more than 75% of patients. And this score was validated in Desktop 2, which is an international prospective study. And then we have Desktop 3, which is a randomized phase 3 trial, randomized patients with platinum-sensitive relapse and positive ESGO score, and who did in this trial demonstrated a significant survival advantage in favor of cytoreductive surgery, both in PFS and in overall survival. Then we have the surgical results from the GOG 213 study, which is also a randomized phase 3 study, which included patients with platinum-sensitive relapse PFI more than 6 months. But in this study, there was no selection score for surgery, and the authors did not find any survival benefit in favor of a secondary cytoreduction. Finally, we have the SOC1 trial, which is also a phase 3 trial that has been published in 2024. This trial also used a selection score, which is the I-model score, using 6 criteria, as you can see here. And when the score shows low risk, then complete cytoreduction can be predicted in the majority of patients. And even if the initial results of this trial failed to demonstrate a survival advantage in favor of surgery, when we consider patients that have crossed over surgery, we see that we obtain a survival advantage in favor of surgical cytoreduction with an adjusted hazard ratio of 0.76. Here you can see the differences between these trials. So main difference, of course, are the trial results, with 2 trials that can be considered positive, the Desktop 3 and the SOC1 trial. There are differences in the patient population in these 3 trials, and the main difference is selection criteria with the use of a selection score, the ESGO for the Desktop 3 and the E-model score for the SOC1 trial. And finally, bevacizumab was used in a majority of patients of the GOG trial. So let's move to our last question, which is what is the place of HIPEC, or the benefit of performing HIPEC after chemotherapy for platinum-sensitive relapsed ovarian cancer, with the results of the SHIPOR trial that have been published in 2024. So the rationale for HIPEC is based on the synergy between the pharmacologic activity of intraperitoneal chemotherapy and hyperthermia, which is going to enhance the cytotoxic activity of chemotherapy. There are ongoing or finished randomized phase 3 trials that have assessed the benefits of performing HIPEC for advanced ovarian cancer, either in the primary setting or in the relapse setting. So after chemotherapy, we have the most important trial, the OVPEC-1 trial in the primary setting, and the cheaper one in the relapse setting. So I will quickly go over the OVPEC-1 trial, which included patients with stage 3 ovarian cancer after 3 cycles of neoadjuvant chemotherapy that were randomized into interval debulking surgery with or without HIPEC, followed by 3 cycles of chemotherapy. The primary endpoint of this trial was progression-free survival. And as you can see, this is a positive trial because the author demonstrated a disease-free and an overall survival advantage in favor of HIPEC with an hazard ratio of 0.7 for overall survival. And finally, we have the results of the cheaper study that have been published last year. So this study included patients with a first relapsed ovarian cancer, a PFI of more than 6 months, which were chemosensitive, so response to chemotherapy, and in which complete cytoreduction could be achieved. So patients underwent 6 cycles of chemotherapy, and then they were randomized during surgery. After surgery, once cytoreduction was completed, they were randomized into HIPEC, also using cisplatinum, or no HIPEC. Patients were stratified according to center to residual disease, into complete resection or minimal residual disease of less than 25 millimeters, PFI, or planned PARP inhibitor. And the primary endpoint of this trial was overall survival. And here you can see the results of the cheaper trial, which is a positive trial because there was a significant survival benefit in favor of HIPEC, both in progression-free and in overall survival. Both arms were well balanced, but there was significantly more grade 3 and more toxicity in the HIPEC arm. But once the sodium thiosulfate was introduced following the OVPEC-1 study, the morbidity, the renal toxicity was reduced. And the quality of life results from the cheaper trial were presented in ESGO 2024, showing a similar quality of life 1 year after surgery. So in conclusion, concerning lymphadenectomy after interval debulking surgery, we now have the results of the Caracal trial, so we can conclude that there is no benefit to perform lymphadenectomy after primary or interval debulking surgery for advanced ovarian cancer. Concerning surgery after for platinum-sensitive relapse, we have 2 positive studies, the Desktop 3 and the SOC1. If we consider the crossover to the surgical to surgery, and we can say that cytoreductive surgery should be considered for patients with platinum-sensitive ovarian cancer relapse. And our last conclusion is on HIPEC after chemotherapy. We have the results of the OVPEC-1 trial for the primary setting, and now the results of the cheaper trial for the platinum-sensitive relapse. So we can conclude that HIPEC is an option after IDS, but also after 6 cycles of chemotherapy for platinum-sensitive relapsed ovarian cancer. And I thank you very much for your attention.
Dear colleagues, this is my pleasure to discuss with you the most recent achievements in vaginal and vulvar cancer. This is my disclosure. As you know, the epidemiology shows that vulvar and vaginal cancers are rare disease. There is for vulvar cancer an increasing incidence with two peaks, one epidemiological peak that affects patients less than 60 years old and that is related to HPV exposure, and another peak that is preferentially observed among the older patients in the context of lichen. We have a few prospective trials, and those mainly address the question of local treatment, surgery and radiotherapy. The place of systemic approaches is not very well defined in the literature. For vaginal cancer, we have no randomized study, and therefore all the level of evidence comes from retrospective series. As you can imagine, we have very few well-conducted prospective randomized trials in both sites, but we had the opportunity in the last years to have the first joint guidelines for the management of patients with vaginal cancer. And these guidelines clearly highlight the central role of radiotherapy, of high-tech radiotherapy based on intensity-modulated radiotherapy, image-guided adaptive brachytherapy, and plus or minus concurrent chemotherapy to cure these patients, with some target aims that have been defined for brachytherapy treatment with dose escalation process up to 85 gray, depending on the cases. And what has also been highlighted in these guidelines is the role of complex brachytherapy procedures involving intravaginal and interstitial applicators according to the tumor size, according to the patterns of tumor response after radiotherapy. In parallel with the publication of the guidelines for treatment of vaginal cancer, we had an update on of the European guidelines for the treatment of patients with vulvar cancer. This update very well defined through decisional trees the optimal management of vulvar cancer that takes into account the characteristic of the resection margin with a role for re-excision when re-excision is possible with minimal morbidity, the role of the sentinel lymph node procedure has also been highlighted with lymph node staging that depends on the tumor lateralization. We also define in these European guidelines the role of further treatments after sentinel lymph node technique that will depend on the size of the lymph node metastasis, with possibility to do inguinofemoral lymph node dissection that is recommended in patients with macrometastasis, but the possibility to do radiotherapy in the context of micrometastasis. The optimal treatment of patients with proven groin node metastasis is also discussed, as well as the place of adjuvant treatment, and you can easily access these decisional trees to help you in your practice. In these guidelines, we also discussed the optimal treatment for advanced cases with three options, either surgery, definitive chemoradiation, or neoadjuvant chemoradiation followed by surgery. What has changed in terms of practice is that there is an increasing role of dose escalation for vulvar cancer. We know that the local control is still not optimal with radiotherapy, and that's why there is a need to increase the dose to achieve better local control. We have an important prospective phase 2 trial that tests a strategy relying on dose escalation with intensity modulated radiotherapy in combination with cisplatin gemcitabine, and this prospective study reports with 51 months of follow-up high local control rates and a PFS at 1 year of 74%, which is quite high compared to what has been published in the past with lower doses of radiotherapy. There are lot of ongoing trials, and there is much expectation from this trial to refine the optimal treatment of vulvar cancer. I don't go into the details, but you can have a summary of these trials in this recent publication in JCO. For patients with metastatic disease beyond the pelvis, we don't have any high level of evidence study to help to define the optimal treatment. But most of the evidence comes from cervical cancers, and the treatment relies on platinum doublet chemotherapy. And then if you have access to immunotherapy, you can discuss inhibitor of PD-1 for patients with a CPS at least 1, and bevacizumab is also an option to be discussed based on what has been shown in cervical cancer. But these clearly highlight the need for more inclusion in clinical trials dedicated to the situation of vulvar cancer. If we want to summarize what has changed in clinical practice in 2024, we didn't have a major study that completely changed the practice, but we have an increasing number of data that help defining the optimal treatment with the first joint guidelines published in 2023 on the role of modern radiotherapy, brachytherapy, and surgery for vaginal cancer. We also had the update of the guidelines for vulvar cancer the same year, and these guidelines better define the respective places of surgery in radiotherapy and the increasing role of dose escalation. For systemic treatments, most of the level of evidence derives from cervical cancer, and there is therefore a major need for more data coming from prospective study, and we can expect that this study will come in the coming years.
Greetings to everybody from London. It is my great pleasure to present within the OncoAlert, and also thank you to ESGO for allowing me to present the surgical treatment of vaginal cancer, the new advances in the field, and to present you our new guidelines, which are now already almost a year old, however, a product of a long work together with our with our colleague societies ESTRO and COP, and with my co-chair Reminu and Gabriel Calamenus. These were evidence-based guidelines for the management of patients with vaginal cancer, including adults and children and adolescent patients, in an effort to cover comprehensively the diagnostic pathway, the surgical, radiotherapeutic, and systemic management of patients with this very rare disease. And for that reason, we have tried to do it following the ESGO SOP by, after nominating a multidisciplinary team of experts, to have really identification of the objective scientific evidence so that we can formulate our guidelines in an objective and non-biased way as much as possible. As a part also of the ESGO guidelines, what was a key was that once we had the first draft, we sent it to all international reviewers, experts in vaginal cancer treatment. So many thanks to many of you across the world, so that we get feedback, which we have incorporated. So what are the principles of surgical decision-making process, including patient stratification and consent? I think we all agree that decision-making regarding treatment across all stages should be based on objective parameters, and also after discussion, a multidisciplinary team. Important is that patients know what we recommend, but also know their alternative options. Not everything, not one size fits all, not everything is for everybody, and not what we think is the best way is indeed the case for every patient. So patients need to be consented for all alternative options, which is one of the main keys of today's consent. So adjusting and tailoring treatment to individual patients' needs. So let's go more to practicalities. What is the management of stage 1? So T1, N0, M0 in adult patients, surgery versus chemoradiotherapy. So these both strategies are possible for the initial management of this disease with a curative intent. Both options should be discussed if feasible. Unfortunately, we have to acknowledge that there is no randomized evidence for this comparison. It's only retrospective series. We have written very well in our guidelines how the steps should be. So, of course, histological diagnosis before doing anything. And as with the principle of cervical cancer, we should try to avoid combined treatment, so and surgery and radiotherapy. It should be either the one or the other. So we shouldn't operate patients where we think that surgery will not be enough and they will need a consolidation radiotherapy. The surgical route should be considered only for small-sized tumors, so up to 2 centimeters, and this lesion should not be close to areas that are tricky to resect and will be mutilating for the patient, like urethra, like anus. Depending on where the tumor is, whether it's in the upper vagina or in the lower vagina, the dissection and lymphadenectomy should be, if it's in the upper vagina, to include the inguinal, like cervical cancer, and if it's in the lower vagina, like a vulvar cancer. Fertility sparing approach is possible, in which case we have to live in the uterus, but again, very selected and very well-defined scenarios. Unfortunately, the use of sentinel lymph principle is not yet established in vaginal cancer, and I think it will take a long way to do so. So when performing a lymphadenectomy, it will have to be a systematic one. What happens in childhood and adolescence? The main histological types is the rhabdomyosarcoma, but also we have germ cell tumors. Clear cell carcinomas are also present, but less common. The vaginal rhabdomyosarcoma is almost always of embryonal type and represents less than 2% of all RMS in general. However, it is always a dilemma in small children because here functionality is paramount. So again, here full clinical examination, histological diagnosis. We should at diagnosis avoid any resection. It's just a small biopsy in order to set the diagnosis. These tumors are highly chemosensitive, so we shouldn't mutilate the children by resecting large parts of the vagina. But apply first alternative treatment options. If we do so and then there is residual tumor, then we have to see where this residual lesion is, how big it is, and how easily resectable it is in order to preserve function. A minority of patients may undergo a limited but complete tumor resection with organ preservation, but this is tricky and therefore this needs to be done only in multidisciplinary teams. In terms of the germ cell tumors, surgery should be reserved for situations where we don't have a response to chemo. This again is a very chemo-responsive tumor, so it needs to be balanced between surgical radicality and chemo sensitivity. Very important, no matter what we do, if we operate, we need to have as a consideration the neovaginal reconstruction. Women who are functional in terms of sexual intercourse, they need to be consented and they need to be explained the option of neovaginal reconstruction when we have to remove large parts of the vagina. There are various reconstructive options from the gastrointestinal tract, from myocutaneous flaps, artificial material use. So there are many uses. We need to see what is tailored to every patient, and of course discuss with the patient the potential different morbidity profiles that consist of fistula formation, stenosis, prolapse, odor if it's a GI tract. So these are all things that we need to discuss with the patient. Especially in children and in adolescents, it is very important that the timing of any neovaginal reconstruction should be placed before the start of menarche. Otherwise, we have cryptomenorrhea and uterine obstructive symptoms, which are dramatic. Accentuation should be reserved only if everything else has failed, especially now with all these available treatment options. This should be really the last resort. And it is really, again, here a keyword, multidisciplinary and specialist teams. So what has changed in clinical practice in 2024? Surgical treatment should be within a multidisciplinary expert setting with the adequate infrastructure. We have to centralize care. These are very rare cancers. So we have to actually ideally concentrate them within supra-specialized referral centers. Of course, as with any rare tumor, enrollment of patients in clinical trials is of key and of paramount importance. And we should use the patient-reported outcome measures in order to, at the end, have tailored treatment for our patients. Thank you very much.
In the upcoming 5 minutes, I will give you an update on the surgical treatment of early-stage vulvar cancer. When talking about early-stage vulvar cancer in this presentation, we focus on patients that are eligible for the sentinel node procedure. Those are patients with unifocal squamous cell cancer of the vulva, smaller than 4 cm and without suspicious nodes on imaging. When performing a sentinel node procedure in this group, the groin recurrence rate after a negative sentinel node is 2 to 3%. The introduction of the sentinel node procedure brought about a major decrease in treatment-related morbidity, and survival for sentinel node negative patients is excellent. In case of metastatic sentinel node, further treatment is warranted because of more metastatic lymph nodes might be present. Crohn's V2 showed that in case of metastasis smaller or equal to 2 mm, radiotherapy is a safe alternative for a lymphadenectomy with less treatment-related morbidity. This study also showed that for patients with metastasis larger than 2 mm, radiotherapy alone up to 50 Gray was not sufficient in preventing groin recurrence. Therefore, a lymphadenectomy is still the standard treatment in this group. Currently, we are working on a long-term follow-up of these patients. Recently, FIGO introduced a new staging for vulvar cancer. They also introduced a new method for measuring depth of invasion, and with this method more patients will have microinvasive disease and can therefore be spared the sentinel node procedure. So that's something positive. However, data on this new method are very limited, as seen in this short overview of the 2 studies that have been published on this subject. Therefore, more data are required to safely introduce this method, and until then the decision on groin treatment should be based on the old method. So talk to your pathologist about this and be sure they do not just take this over. We are currently working on revision of all Crohn's V2 participants to compare both methods of measuring depth of invasion, and hopefully we can report on this the upcoming year. Last year we also worked on translating the new ESGO guidelines into the Algorithms app. This month the update went live. To look them up, update your app. As far as I'm aware, 3 clinical trials are ongoing in primary treatment of early-stage vulvar cancer. Crohn's V3 is investigating whether chemoradiation is a safe alternative for a lymphadenectomy in patients with sentinel node macrometastasis. The Apollo study is testing pembrolizumab in neoadjuvant setting in patients that are planned for primary surgical treatment of vulvar cancer. The STRIVE study is planned now and will randomize patients with surgically treated HPV-independent vulvar cancer with narrow margins or DFIN or abnormal P53 in the margin between re-excision and active surveillance. When thinking about future trials in vulvar cancer, it's important to include the differentiation between HPV-associated and independent disease. More and more is known about these subtypes of vulvar cancer. HPV-associated disease is relatively seen in younger patients related to smoking and immunodeficiency and has a better prognosis, less local recurrences, and can be distinguished by performing P16 immunohistochemistry, which is block positive in HPV-associated disease. HPV-independent disease is related to lichen sclerosis and shows often P53 mutations. Part of the tumors is HPV-independent and has no P53 mutation. This is a relatively favorable subtype in the HPV-independent group. Therefore, in vulvar cancer trials, HPV status should be taken into account to learn about the differences and to work towards more personalized care for vulvar cancer patients in the future. There was not much practice changing in 2024, but the ESGO app will make practice more easy. Furthermore, based on the results of CORNSV2, radiotherapy is a safe alternative for lymphadenectomy with less treatment-related toxicity in patients with sentinel node micrometastasis, and hopefully this treatment option is now standardly discussed with these patients. And there's more and more awareness about HPV-associated and independent disease. And if there isn't, there should be. Then what is coming in 2025? The data of the long-term follow-up of CORNSV2 will become available. Also, we hope that this year the data on the safety of the new method of measuring depth of invasion will become available. Furthermore, the ongoing studies will still be ongoing in 2025. The results of these studies will take a bit longer to become available. I thank you for your attention.
Hi, I am Kim Hulsje. I'm a cervical cancer survivor from the Netherlands. I'm a patient advocate and I am the co-chair from ENGAGE, which is the European Network of Gynecological Cancer Advocacy Groups, which is the ESGO network of patient advocacy groups. My presentation is about the importance and added value of patients' involvement, specifically on clinical trials and guidelines. That's what I will be focusing on today. ENGAGE has a clinical trials work group, which is, we exist since 2019, and since 2019, we've already trained 22 patients. So these are patients who are now patients experts in clinical trials. We've been trained by listening to webinars, reading study books, doing exams, and also by face-to-face meetings. And that way we've been able to learn and understand about clinical trials and their designs. Last November, we were gladly invited to Strojna in Italy to be part of the ENGOT Kine Cancer Academy. And there we were able to learn from amazing people like Jonathan Letterman, Isabelle, Ray-Coquard, and many more. And we learned a lot more on clinical trials, but we were also able to present ourselves. So everybody that you see here on the picture, this was in Italy, everybody who was there presented themselves and explained why they are part of the clinical trials group and why it is so important to them. And for example, I shared how important it is for me because I had cervical cancer 10 years ago. And back then, if you would have a recurrence in cervical cancer, that was really, really bad news. And really up today, it's still not a good treatment, but it's not as bad because there are possibilities with immunotherapy, etc. So this is, of course, all thanks to clinical trials. So everybody has their own reasons why they are part of this group. Another thing that we do in this clinical trial group is talking about the differences in Europe between the countries. Like in some countries, like in the Netherlands, but also like in the UK, patients, experts need to be involved in clinical trials. Otherwise, there won't be a clinical trial. And in a lot of other countries, that is not the case yet. So this is something we're really trying to advocate for. And in several countries, it's very easy to find if there is a clinical trial on your tumor type and if you're eligible for that. And in some countries, patients are really have to rely on their doctor to tell them if there is a clinical trial for them and whether they're eligible. So these are things we as a group, advocate for. This will eventually be the same all throughout Europe. Another very important subject for us for patient involvement is the guidelines. ESGO has a guidelines committee, and for 2 different guidelines we have been part of already. The first one is the endometrial cancer guidelines updates. And Barlevy was the patient advocate from Engage, who was part of it. So from the start, she was there and talking with all the other experts, medical experts, on the new guidelines. And one thing she has done in this guideline is change the wording of within the guideline of an aggressive tumor, because just the word aggressive tumor can be already very devastating for a patient to hear. Another guideline that Anna Medelar has been part of, from the side of Engage, is the management of cancer in pregnancy. And new in this guideline is that the two patient experts who were involved got to write their own chapter. And this was, of course, very, very great and good that they could do this. And what they wrote about mainly was on shared decision making, the importance of it, supportive care during and after the decision, but also about possible late effects, like being able to become pregnant again later in life. Each guideline has already been reviewed in the past. The ESGO guidelines been reviewed by patients, but right now we also determined that with ESGO that there should always be a patient expert present during the whole process of a new guideline or either revising a guideline. Yes. In 2025, which is very exciting, we as Engage, we started we thought of a new idea for a guideline, and we brought, as Engage, so as patient expert, we brought the topic to ESGO. And this is a new guideline that will be written by ESGO, Engage, and ESTRO, and it will be on the prevention and management of complications affecting sexual quality of life in gynecological cancers. So the interesting thing is that this will not be on psychological part of sexual health, but on the physical part of vaginal toxicities, for example, and how to prevent these whenever and wherever possible. So it's a great achievement and something we're very proud of, that we were able to initiate this new guideline. And so it's for us, it's very important that we as patients are involved with this. Of course, the doctors have all the medical experience and knowledge, etc. But the focus is mainly on the outcomes and less on quality of life and like the patient as a whole person, and not just on the medical part of a patient. So I want to close with saying, use us patients. A lot of us are educated, patients with lived experience. Clinicians have blind spots, and you can't help it because you have not had cancer, and it's really, really different if you had it yourself. It's very important, though, to be working with patient experts. I know that there are doctors or researchers there that can be reluctant using patients, because if it's a patient that is not educated, so if it's not a patient expert, it might be too personal, it might be too close, they might not be far enough in the process. So really make sure, work with patient experts, but make sure the patient experts, so they're educated and able to do this job. Thank you very much.
Thank you for joining us for Day 5 of the Colloquium. We invite you to join us again tomorrow as we review the year's highlights in hematology, lymphoma, sarcoma, melanoma, and immunotherapy. We have an outstanding faculty leading this discussion, and once again, we extend our heartfelt gratitude to our partners at ESO, ESGO, MASC, CIOG, as well as our collaborators. A special thanks to Roche and Pfizer for their support of this OncoAlert Colloquium, and thank you for joining us today. And thank you for being a part of this OncoAlert community.